Good morning, everyone. My name is Sai. I'm one of our unaccrediteds this year. For our first presentation, I have prepared a talk on traumatic growth arrest and its sequelae. So physeal injuries represent around 20% of fractures in children, and the distal radius is most commonly affected, with incidence varying with age and most commonly affecting adolescents. Now, while complications arising from traumatic physeal injuries are quite rare, they are the most common cause for growth arrest, and they are often very predictable and preventable. So today I will review physeal anatomy, the risks for traumatic growth arrest, its consequences, and dealing with these in children. So to touch on the anatomy, the epiphyseal plate exists between the epiphysis and diaphysis in the metaphyseal region and is responsible for longitudinal growth. The first zone is a germinal zone with the stem cells. These then differentiate into chondrocytes, and in the proliferative zone, they proliferate, form extracellular matrix, which contributes to growth, and this matrix resists shearing forces. In the hypertrophic zone, cells enlarge and then further lengthen. There is very little matrix here, making this area relatively weak, and it is where most physeal injuries occur. This then transitions to the enchondral ossification zone. Here, the chondrocytes die and provisional calcification occurs, and this calcification of extracellular matrix also is resistant to shear stress. In this area, osteoclasts and osteoblasts also then start to create and remodel bone on this cartilaginous scaffold. The zone of Ranvier and ring of Lacroix are other important aspects of the epiphysis, and they make up the peripheral structure. The zone of Ranvier is a wedge-shaped zone at the edge of the physis, containing osteoblasts, chondroblasts, and fibroblasts, and is responsible for the peripheral growth of the physis. Peripherally to this, there's a perichondral fibrous ring of Lacroix. It attaches to the fibrous area of the zone of Ranvier, as well as to the periosteum, stabilising the epiphysis and metaphysis. In terms of vascularity, there are three blood supplies. The main comes from the epiphyseal side, supplying the germinal and proliferative zones. The metaphyseal vessels form loops in the area of the hypertrophic zone, and this is where chondrocyte degeneration is occurring. This metaphyseal blood supply provides nutrients to the new osteoprogenitor cells, which are forming new bone on the cartilage scaffold. And then thirdly, there's the perichondral perichondral artery, which runs into the ring of Lacroix, and it provides blood supply to the periphery of the physis and zone of Ranvier. And so the hypertrophic zone is very notably avascular as well. So as mentioned, physeal injuries represent around 20%, and complications from these are quite rare, somewhere between 1% and 9%. So how do we know which children with a traumatic physeal injury will proceed to growth arrest? So firstly, it's really important where the location of the injury is in the physis. Where the germinal zone is injured, and these are more likely to develop growth disturbance. And we look to the Salter-Harris classification for this, which I'll present in later slides. The energy of the mechanism, it is another key predictor for growth disturbance. It logically follows that a high energy mechanism, the more significant the bone and soft tissue injury. And crash injuries and fractures that cross the germinal layer are both much higher energy, as well as fractures with greater initial displacement, and those requiring multiple reductions, operative intervention. And the site of the physis is also highly relevant to prognosis. So which physis is involved? Those in the upper limb have much lower rates of growth disturbance than those in the lower limb. In particular, the distal femur is at risk, as well as the proximal femur and distal tibia. So this classic paper by Salter and Harris on epiphyseal plate injuries informs the Salter-Harris classification, which is most commonly used. It's an anatomic, easy to remember, and can help plan treatment and prognostication after physeal injuries. So here you have the Salter-Harris-1, which is a separation through the growth plate, the Salter-Harris-2, injury through metaphysis and epiphyseal plate. Here, a Salter-Harris-3. This fracture is intra-articular, exiting through the epiphysis and will involve the germinal zone. The Salter-Harris-4 goes again through the epiphysis from the metaphysis of the distal tibia here right through into the joint, and again involves the germinal zone. And this type 5 is a crush injury, which obliterates the germinal zone. As such, type 3, 4, and 5 have the highest risk of growth disturbance. And here I'd like to mention Harris lines. These are transverse lines of increased density on X-ray, and they occur as bone growth slows after injury. And this is because newly forming trabeculae get backed up and line up in a more transverse fashion. They're a useful indicator of the health of the physis. In terms of normal growth, as you see on the left, these grow parallel to the physis and it's symmetrical to the uninjured side. In slowed growth, the lines are closer to the physis than on the uninjured side. When a complete physeal injury occurs, the Harris lines are absent near the injured physis. And in partial injury, you'll see an angled line, which leads you to suspect a bony bar. So consequences of physeal injury. Most of these recover well. For example, most Salter-Harris-2 distal radius fractures. We see evidence of growth on X-ray, and we know this occurs over time because we undertake serial review. There can also be development of a physeal bar, and we know this occurs over time with serial review, as there will be asymmetrical growth, angulated Harris growth lines. There can be angular deformities, evidence of a bar formation, as you see here, shortening and articular surface deformities. These partial arrests can occur either peripherally or centrally, and those that are peripheral are more likely to lead to angular distortion. Central physeal partial arrests may lead to articular distortion as well as potentially angular deformity if eccentric. And you can also get linear bars in Salter-Harris-4 fractures. Another consequence will be premature closure of the physis with complete closure and cessation of growth. And this will lead to shortening of the bone. On imaging, you'll see physeal blurring, sclerosis, asymmetrical and loss of Harris growth lines when compared to the other side. And then fourthly, you've got slowed growth. So again, asymmetry, and the Harris lines will be much closer to the injured physis on the affected side than on the unaffected side. So how do we know clinically significant deformity will occur? And this depends on the amount of growth remaining and which physis is involved. So for example, in terms of growth, a 7-year-old with a growth arrest to a distal femoral physis is much more likely to develop clinically significant issues, as he has more growth remaining than a teenager who is very close to skeletal maturity. The involved physis is also important. Differential growth occurs at each physis, with growth at rest at the distal femur leading to much greater shortening than at the distal tibia, as 40% of the leg's growth occurs at the distal femur. Also, it's important, I think, to be aware that growth disturbance in the paired long bones, such as the tibia and fibula, are much more clinically significant because these will cause angular deformity at these joints as an unaffected physis continues to grow. So here, with the tibia showing growth disturbance and bar formation, the fibula continues to grow and leading to a varus deformity of the ankle. By determining the growth remaining, we can also then predict the leg length discrepancy at maturity. And this is important to be aware of as it guides monitoring and management. So to calculate the amount of time remaining for growth, first we determine skeletal age. There are multiple methods for this. We can ask our radiologist to comment based on serial wrist and elbow x-rays. We can use the Grulich and Pyle Atlas of Hand x-rays using left PA images of the hand and wrist. Other methods include the Sovgrain de Meglio for reviewing ossification at the elbow. Next, to determine the growth remaining, We must look at the speed of growth. And there are numerous ways to determine this, and these are all based on the Green-Anderson growth tables. The Menelaus rule of thumb method is most commonly used, based on the concept that boys will stop growing at 16, girls at 14, and then considering the amount of growth at each physis, as demonstrated here. Our paediatric surgeons also commonly use the Paley app, which relies on the multiplier method. And this is a really simple and easy way to predict limb length discrepancy at maturity. And it also can allow you to calculate the age for epiphysiodesis for desired correction and growth remaining. Now, which physis is involved? I've already touched on this, but different amounts of growth occur at each physis. And here you can see the percentage growth of the limb and each bone by each physis, as well as the mean growth per year. And most growth, as you can see, occurs at the knee, shoulder, distal radius. And those with higher growth are more at risk of clinically significant disturbances after trauma, if this does occur. Here, I thought it was important to quickly mention that the upper limb has a greater scope for compensating with a deformity than the weight-bearing lower limb. Firstly, it compensates better for limitations of range and length at one joint, as it's non-weight bearing and the surrounding joints have excellent ROM. So here you can see the fixed flexion deformity or loss of 20 to 30 degrees extension at the elbow will still allow for most ADLs to be performed, whereas a similar loss of range at the knee would significantly impair walking. Now, it's essential to follow children up who have had a traumatic injury to the physis and to identify any growth disturbance early. And so we must routinely follow up clinically and radiologically at-risk patients, and this depends on the risk. So high-risk children would be those with high energy mechanisms, displaced fractures, and particularly those in the leg. These should have x-rays every 3 months until normal growth is resumed, quantified and documented. I also wanted to mention that Salter-Harris distal radius fractures that undergo multiple reductions or late reduction attempts really also require quite close follow-up, as these are at risk of physeal arrest. Assessment of a child with post-traumatic growth arrest. First, we must take a trauma history, understand the age at the time of the injury, as a younger child has more growth remaining with more likelihood for a clinically significant deformity. We also want to know about the energy of the mechanism, as this higher energy puts at greater risk, the amount of initial displacement, numbers of reduction attempts, and which physis is involved. We also want to know the onset of the deformity, the functional disability, and issues with pain and instability. For examination, we want to look, feel, move. So looking for malalignment. We're looking for gait, any attempts for the child to maintain symmetrical gait with a leg length discrepancy. And this can be accentuated by asking the child to walk fast or run, looking for things like toe walking on a short leg, as well as circumduction to aid clearance of a long leg. We also want to look for, feel for leg length, contractures and neurovascular status, and assess range of motion and joint stability. The block method is the preferred method for limb length assessment. This requires the child to stand on blocks of known height with their short leg and pelvis evaluated for symmetrical position. And this method is inaccurate if there are fixed flexion contractures. So it's important to also assess for these and undertake segmental measurements if this occurs. And you can also measure leg length with tape measure. And once a growth disturbance is suspected or identified, we require further imaging, X-ray of the affected limb to assess fracture union, location and type of growth disturbance, deformity, looking for bars and Physeal lines, Harris lines, as well as we can get full length weight-bearing X-rays to evaluate malalignment and length in the coronal plane. EOS is superseding full length weight-bearing films where it's available, They enable weight-bearing length and alignment assessments in both coronal and sagittal planes, and evaluating mechanical and anatomical axes of the lower limb. CT and MRI are also useful, and these provide information on size, shape, and location of the physeal arrest, and they help decision-making and preoperative planning. And the choice of this is really BOS dependent. CT effectively demonstrates bars, and MRI, as we know, has no ionizing radiation and can provide information on the bars as well as the articular surface and soft tissues. So to briefly touch on management, the overall goal here is a child who at maturity has an equal or near equal leg lengths, pain-free mobile joints, no cosmetic or functional deficiency secondary to deformity. And to reiterate, early intervention to prevent deformity is much more preferable than waiting for a deformity to develop and having to correct it. So when it's detected early, the goal of treatment is prevention. Surgical options depend on the size of the arrest. Epiphysiodesis is the mainstay of treatment based on the concept of inducing or completing a bony bridge at the physis. And these are used particularly when bony bars are large and the patient is nearing skeletal maturity. On the injured side, it can prevent subsequent angular and articular deformity. There are multiple methods percutaneously. These can be undertaken by drilling and burring or curettage. And you can also utilise percutaneous transphyseal screws, which are inserted under fluoroscopy. Resection of physeal bar is also possible, but less frequently undertaken. These are more easy to perform when it's a peripheral bar, and these are burred and filled with fat. And they have better outcomes where it's a smaller bar, less than 20%, 5% ideally, and the child has greater than 2 years of growth remaining. Now, if an angular deformity has occurred, we can preventatively undertake epiphysiodesis or bar resection to prevent a minor angular deformity becoming more significant as the child grows. And for a child at skeletal maturity with an angular deformity, osteotomies can be used to address this. So where there is a growth arrest and a leg length discrepancy, our goal is near even leg lengths and joint height. Under 2 centimetres, they might not require intervention if asymptomatic or may require a shoe lift. For those over 2 centimetres, operative management is indicated for cosmesis and prevent long-term symptoms and optimise function. Here I've just included a very basic overview of treatment options. For smaller projected mismatches, treatment aims to shorten the long uninjured side to minimise the final discrepancy with epiphysiodesis. And for larger leg length discrepancies greater than 5 centimetres, the short injured side will require lengthening. And it can also be possible to shorten the longer side, although this is less frequently undertaken. There are many ways of doing, or there are multiple ways of doing this, and it's much easier to make a limb that was meant to be a normal length, such as in the case of post-traumatic growth arrest, and pull it out and make it longer than it would be to make a limb that was meant to be short, longer, for example, in the case of congenitally short limbs. In terms of techniques, there's internal techniques such as nails, precise or fit bone, and external techniques for corrections, and these include monolateral and hexapod frames. And it's also possible to achieve complex correction, usually with a frame. Counselling is a really key aspect of patient care, providing patients and families with an understanding of the severity of the discrepancy, and it serves as a foundation for determining appropriate treatment for each patient. So in terms of take-home points, I think prevention is extremely important, being aware of who to monitor, close monitoring for those with high energy mechanisms, and taking a good trauma history at the time to be aware of these. At-risk physes need to be followed up, so distal femur, distal tibia particularly, as well as those who undergo multiple reductions. So our Salter-Harris 2 distal radius fractures, which we frequently see, if they've had 2 reductions or more and they've had late reductions, we really need to make sure they're closely followed. And then finally, as registrars and residents, it's important to be aware of skeletal age, how to calculate this, methods of calculating growth remaining and the facile growth rates and contributions to growth.